optimizing the HIV treatment continuum. She's the coordinator of treatment and care in the Department of HIV/AIDS at the World Health Organization. Thank you, Meg, for being here.
Okay, thank you. And I don't have 100 slides, but I do have several slides, so I'll try to make this as interesting for all of you as possible as I go through. And I do want to say that we want to thank the IAPAC and everyone for the invitation to come and speak. I think this is the third time that WHO or at each of these that we've been here to speak, so we appreciate it. This speech was going to be given by Dr. Gottfried Hernschel, but he's in the European Regional Directors meeting, and so for that reason has asked me to present. So I'll be talking about the optimization of the HIV care continua, as some of us are calling it, or the continuum. And I am going to add in care and a tiny bit of prevention in my presentation. And I will give you some population-specific examples and interventions, our WHO approach to optimizing the treatment care continuum, and then how this translates into country-level implementation and programming. So I need to start, because we've already heard about it, of the 90-90-90 targets, and I think WHO welcomes these targets because they certainly talk to things that we hold very important, truly about the cascade of care, quality indicators, because looking to and finding people who are fully suppressed is a good measure of quality. And I think it really speaks to the kind of work that we have been doing in terms of drugs and diagnostics and service delivery under what used to be called the Treatment 2.0, our optimization work. That's now what we're calling and everybody is speaking about in terms of innovation. So we have been working very closely, and I'll get into more specifics on sort of new FDCs, diagnostics for rapid tests, point of care, CD4 and viral load. And certainly we've already been doing lots of work in terms of normative and technical guidance on bringing ARVs closer to the patient in the community. I can't do a continuum or a cascade presentation without showing probably the first one that we've seen organized in this way in the United States, and this was from Gardner and all. And what you can see is in the United States in particular, we had a viral load suppression in this cascade of care, starting from those infected all the way down to those undetectable, of only 19%. Now on repeat, iterations of this, and then with more data, the United States were getting a little better, but are not that great. And so 90%, or 72% if we use the cascade, multiply it out by each subpopulation, is even a large, ambitious target for the United States. You saw this earlier from Dr. Sawada, where we showed that in Africa and in sub-Saharan Africa, we have a viral load suppression rate of approximately 29%. So even this one shows that they're doing quite a bit better than the United States. And I like this slide. I believe this comes from a paper from Wafa and her team that compares United States, Britain, including MSM, and then Mozambique. And Mozambique is in the red in terms of the cascade, those infected, diagnosed, linked to care, retained in care, needing ART, on ART, and then virally suppressed. And we can see that the United States and Mozambique are not far off in terms of the final outcome there in terms of viral load suppression. So these are another example of what the ambassador was talking about. It's very important to be able to use data, and I think that Cascade is a very good example of data use that can go into populations as well as into specific locations. This, and for those from British Columbia, I'm sure they would be happy to see that, you know, from their use of the cascade, we can start to see that over time and by cohorts, you can see in the light blue that gets smaller and smaller is the percent with a high viral load going down, and in the green, the percent over cohorts with a suppressed viral load going up. So what are some of the challenges with the continuum of care? And I'm going to borrow a slide from Wafa, is that we know that many people are unaware of their HIV status. They come late into HIV diagnosis. There's failure of patients to be linked to care, little or late initiation of the ART, or this delayed pre-ART period, and inability to achieve viral suppression or to measure viral suppression, which we will be finding currently in the future until we get viral loads scaled up. Many of you may be aware of this slide. It's a slide that comes from the IDEA cohorts, and it's by Matthias Egger and his team. And every year they sort of monitor in their IDEA sites at what CD4 is the median CD4 at initiation. And in the past, in the dark brown slides, you have a very low, less than 100 CD4 count. And as you go through the years, and up to just 2013, where we are now, we see that the median CD4 is increasing, but by no means is it even at 350, which was the 2015 guideline, 10 guideline, and it's not yet near, in many of these countries, close to what we're recommending in 13, I'm getting all my years messed up. And we also know that the cascade is not linear. And this is a nice modeling piece from Tim Hallett, which many of you may have seen. It talks about the side door. And those of you who care for patients, you know patients come in, they leave, they go through the side door, they take a break, and then they come back. And a lot of our measuring systems don't account for that period of rest or returning into the cascade at different points in time. And so sometimes we're either overestimating the loss to follow-up or underestimating the viral load suppression that could be there if we were following all patients in where they are being seen locally. And we also know that there's too many people being lost to follow-up when we start to look at this. And we have seen over in the data that we present from the WHO that serially the loss to follow-up increases with the duration that patients are on therapy. But we also are starting to see a phenomenon coming out of South Africa that in this programmatic review in last year in 2013, 2014, that progressively earlier cohorts, so those people who are starting now, the last 2 years, are having a much more rapid loss to follow-up. Now, this may be data error that has to be checked and corrected, but it also is concerning that is there a sort of number at which you get a patient-doctor or a client healthcare worker ratio or community worker ratio where the system is just somewhat overwhelmed and cannot keep those people in care? Or is it as systems get larger and patients have many options with more places to go that they're not being followed serially and that there needs to be better M&E systems to be able to keep them up and keep them recorded in the systems? We also know that this cascade is a powerful tool to then do what we've been asked to by the ambassador today, is look at populations, look at specific areas. So many of these cascades are coming up in the United States for men versus women, by age range, by location. And I think that this is a very useful tool to then be able to target some interventions to improve the leaky cascade. So that's what I'm going to spend some time on right now, is what do we see in certain population-based cascades, and what are some of the interventions that WHO with partners are working on to try to address some of that leaky cascade. So this is a presentation of the pediatric cascade. The blue is where we are, that HIV births 100% of, if you start with your pool of 100% of births of from an HIV mother are identified, but then we have this gap in red, that there's no testing in birth, so we have to bring that up. And if they don't receive a PCR, then we could use a point of care, PCR or EID or early infant diagnosis approach. And if the mother doesn't receive the results and the child doesn't start treatment, it may be because ART has not yet been decentralized. So those are some distinct interventions that could be done to improve that cascade. And I should bring up that UNICEF and WHO, along with several other partners, have been working on the Double Dividend initiative since 2013, which is really to look at interventions that look at integrating the pediatric testing and pediatric ART into the child survival activities. And in particular, I think this was brought up, and it will certainly be bolstered and supported by the work from the ACT, the PEPFAR and CIF initiative, as well as the DNDi and UNITAID initiative for drugs. But it's really to look at how can you operationalize and get an added benefit from the child survival group for wanting to take on HIV. And some of that might be that there's a package of care that delivers care for diarrhea, essential antibiotics, etc. and then increase testing in nutritional settings or other settings where children are just getting missed and left behind. It's an issue, it's a challenge to try to bring the child survival specialists on board, but I think that's the place where we'll start to see actually movement in the lack of initiation of ARV for children. We also know, and it wasn't yet brought up here, but WHO is really taking this very seriously, as are many other partners, including UNICEF and UNAIDS. But we're seeing a rising death in adolescents. Now, some of us might say, well, this might be a measure of certain children who have been infected perinatally and are now surviving, and they're long-term survivors either on or off ARVs. But it also speaks to, we don't know age disaggregation about these data, we don't have good Cascade data on adolescents, and we don't know necessarily good interventions to reduce that mortality and morbidity among adolescents. Plus, before they get infected, how do we keep them from getting infected, if indeed they're getting infected in older childhood or pre-teenhood? I also want to say that we use the Cascade very usefully as well in TB HIV. And so this slide comes from Diane Havler. And despite the fact that we've had great recommendations about integration of care for TB HIV, that all TB patients should be tested for HIV and is immediately started on ART either within 2 weeks if they have a very low CD4 or a little later if they have a higher CD4 count, we still don't have maximal integration, and we still don't see the reduction in mortality. And this is a place where if we took the low-hanging fruit and really worked on the TB HIV cascade, we could see dramatic reductions in mortality, and it would be a very good place to actually increase the number of people on ART. And that is certainly an area where it's test and treat already, and we're not maximizing the opportunity there. One thing that this is, how do you use innovation to try to maximize the cascade? I think everybody had great hope that expert or TB expert that can look for MDR-TB as well as can identify TB alone would be an answer to trying to get patients quickly onto ART from when they're HIV positive. But what we're seeing is, unless the systems around that are improved, even having an expert and a test that comes back as positive for TB does not mean that the patient will start TB therapy, will be on ART at the right time, and that the mortality will reduce. And a large trial from South Africa showed that. And I think part of the concerns are that we get very excited about innovations and new tools, but new tools only work when you have good healthcare systems and the HR and the human resources to make it work. And some of these innovations require even more healthcare workers than that were previously used with other laboratories. That being said, I think EXPERT is a great test, and we're trying to increase it in its use in the general HIV population to diagnose TB when it's very difficult to diagnose TB. So we've had long-term models of service integration for TB and HIV coming from the WHO that go from pillared, unique parallel services to semi-integration to full one-stop integration. And what we've realized is not one system that works well for every site. And these two have to be prioritized and also developed locally. But ideally, people would like to see one-stop shopping for TB and HIV, but there are downsides. If there's a lot of mixing of people with drug resistance, there could be transmission of drug resistance and or TB among the general HIV population. So you need to also have other systems in place like healthcare infection control. I hope you don't mind. I'm going to briefly talk about the prevention treatment cascade. The reason being is in Melbourne we launched a very important guideline on key populations. And here I'm going to present some of the cascade of care for men who have sex with men. And I think this cascade is very familiar, but what I highlighted in red there is, and this is in Russia among MSM, have they ever disclosed sexuality to a healthcare professional? So what you see is a great drop there, and then a further drop along the cascade so that only 8% were virologically suppressed. So there are many barriers, and it may not just be linkage, but it's what we call some of these communication barriers between each step of the cascade that may be the true barriers of improving the leaky cascade. Again, in India, very similar, probably a very similar cascade that you may see in some other countries. But here what we have among MSM in this area in India that was surveyed, 0% with a viral load suppression. And the main challenge seems to be, as is mirrored in Peru, the drop-off from testing to actually getting meaningfully engaged in care, meaningfully meaning that there's at least a few interactions and then ongoing commitment to stay into care. I put up Swaziland. I think we've lost our minister, but I think it's important here because even in Africa now, we're starting to really measure the cascade in key populations, both among female sex workers and MSM. And across the board, they have lower outcomes on the cascade of care and have challenges in staying in care. Just getting on ARVs, getting viral load suppressed will be even greater challenge. And there are limited access to prevention methods for many MSM around the world. And what we see in low income, there's even a greater barrier to get what we think is primary prevention to MSM. So in many ways, that sets up even a more important reason why the WHO in their key population guidelines, in that guideline development group, they made a recommendation for the first time to consider PrEP as part of a option for prevention for men who have sex with men. And what we know with PrEP is that if taken, if there's good adherence, and in this slide, the green is good adherence for PrEP, or pre-exposure prophylaxis with the tenofovir and 3-TC or FTC combination, we see very good reduction and prevention of new infections. If there's poor adherence in the red and in the orange, again, it doesn't seem to work. So this might be an option for men who are interested. And it's not, we wanted to reiterate because there may have been some confusion about this recommendation after Melbourne. But our recommendation is that this is PrEP, or pre-exposure prophylaxis, as part of an additional choice for prevention in a comprehensive prevention package, including condoms and other approaches. We did not make a recommendation on PrEP for injection drug users, and we continued with our conditional recommendations for other key populations such as sex workers and transgenders, and we continue to have our recommendation of treating the positive person in a serodiscordant couple to reduce onward transmission. Another very strong emphasis on treatment as prevention and using ARVs for treatment as prevention. So I invite you to go take a look at our guideline that came out in Melbourne. I just wanted to briefly say we are now the HIV Hepatitis department at WHO. It'll officially get launched, I don't know when, but we have brought hepatitis into our fold, and we're taking lessons from HIV and applying them to hepatitis. But there's also a huge amount of work in hepatitis that's unrelated to HIV. But I think you'll start to see more and more use of the cascade for hepatitis, and it looks pretty bad as well in terms of outcome, which we're looking for sustained virological response. That may improve very quickly once these drugs are more accessible and more affordable. But we also see that in our 59 focus countries in WHO, that many of the countries and many of the HIV programs are already laying over hepatitis B and hepatitis C programming. And we think that there's a lot to learn from those systems, and that cascade has an opportunity to be much better than the HIV cascade right from the start. So in the last section of this talk, I just wanted to speak a little bit about what WHO does in terms of innovations. And so we work with a lot of partners, but we've been doing this work on innovations and treatment optimization for about 4 or 5 years. And in particular, we work on areas of testing. So we have in a March edition of our guidelines supplement some information on self-testing. And we're now working with Unitate and other partners on a large trial to start to look at self-testing and the feasibility and acceptability. And eventually that will lead to guidelines. So our guidelines are based on data in terms of data that's gathered in the community. And I think there's really a growing interest in self-testing, especially among key populations, as a way to target that first 90 in the cascade. If we can't get them all, let's see how we can incorporate new methodologies and innovations in testing. We've also been working for a long time in drug, and many of you may have heard CADO, or the Conference or Consultation on ARV Drug Optimization, PADO, Pediatric ARV Drug Optimization. We host a Pediatric ARV Working Group, as well as develop an annual pediatric formulary with the IATT, and we are supporting member of the Pediatric HIV Treatment Initiative. So it's based on that communication, where we have ongoing communication with drug companies about what's coming down the pike. What are the big drugs that can be brought together, lower dose combinations, so that they can become fixed dose combinations, and are used injectables. And some of the areas where we're really highlighting work is really getting a very strong first line, that's a single pill, and a second line, that's a single pill, and really optimizing the pediatric cascade with fixed dose combinations. So one thing that we do, oops, this doesn't seem to be working. There we go. This is, we also, with our work with letting industry know, as well as researchers know, it promotes research and trials so that we can then take that information back to our guidelines. So for example, there's a number of studies going on right now that will hopefully feed into a next version of guidelines. And you can see that the timelines vary between 2 and 5 years, because drug trials and drug testing and PQ trials cannot be done overnight. And it's very important to know that these drugs are safe before we start recommending them for global use. So we have low-dose efavirenz, in which we're doing some PK studies among pregnant women and TB-infected persons. We're looking at lower-dose darunavir and how that can be brought into a fixed-dose combination. Use of dolutegravir, either in first or second line in the future. Use of TAF, it's a nice one because it has potentially lower side effects as tenofovir and is a lower size molecule, so it can be mixed with many more drugs. And long-acting formulations, which was mentioned today by Michelle Sidibe, such as injectables. These are a little farther away, probably 5 years down the pike, and I don't think those particularly are going to end the AIDS epidemic. They will be a part of it. But we need to also optimize what we have already and make sure that we're monitoring to see if any of those drugs that we have now are creating levels of HIV drug resistance where we need to make any switches in our first and second line. We need more people on therapy, not only new regimens. We also have quite a bit of work on bringing services closer to the patient. So in our guidelines in 2013, we have task shifting, decentralization, integration, and we also have a section on community-based ARV delivery and community-based testing. So those recommendations and guidances are there for the taking. It's really for the countries and their programs and their supporters and their partners to start implementing this in the field. We also have made recommendations and done a review of using point-of-care testing to encourage rapid linkage. So I'll just encourage you to see that we, in our March supplement, we had quite a bit of information on community-based ARV delivery. What we're doing in the future now, we've already started on our next set of guidelines, where we're collecting data and starting to speak with people and starting on multiple little consultations and scoping to find out what's needed now. And there's certainly some new areas that we think are important. I think WHO has been very good about the what to do. Now we're really working on how to do it, how best to give guidance and guidelines and recommendations to help ministries of health implement what we would like them to do more quickly and more efficiently. And one thing we're having next week, we'll be doing a scoping meeting where we're actually looking at optimal packages of care. So we're not going to optimize drugs, we're going to optimize service delivery. What is the best way to deliver care for those initiating, for those who are ill? What are the package of clinical interventions that they need? Do they need to be treated and screened for crypto because their CD4 is less than 100? Do they need to have TB therapy immediately and fast track because their CD4 is less than 500 and they've got a cough? That kind of information, which is very important for clinicians, but it's also important for the setup of the system, so the system can handle and move people quickly through the system to reduce mortality and morbidity. We also know that patients are starting very early and they're not feeling ill. So what are the kinds of community-based support that they need to stay in therapy over long term when they've never been ill and never felt the need to be on therapy? So we're looking at it from both ends of the spectrum to come in. We're working very heavily on diagnostics. We have a viral load document that was just launched in Melbourne, and currently this week they're having a meeting with 22 African countries in Africa with African Society for Lab Medicine and the CDC to talk about how to scale this up. We have quality care documents and quite a bit of other work now going into a larger diagnostics access initiative. I think lastly I could say, what about implementation science? People have asked, what should we be doing? How should we be encouraging patients, healthcare delivery systems to be evaluating what they're doing? We held a meeting in March of last year to look at this and exactly across the cascade, what are the gaps in knowledge? Briefly, I can say we know a lot about, in the cascade, how to deliver therapy right from the beginning. But in this slide, what you'll see, anything in red means that we don't have a lot of literature about those steps in the cascade. So there's certain steps in the cascade that are very easy to study, others that are difficult. And maybe we should be rejoining our efforts to look at those steps of the cascade so we can figure out how to improve that leaky cascade. And we did this for pediatrics. I just wanted to show you pediatrics. When we start to look at implementation science in peds, we know a lot about PMTCT, but how do we keep children on and start? We're very lacking in data. So from that, we have created a list of a research agenda, which will come out shortly, so that researchers can start influencing the kind of research that they'd like to have their grantees do to help feed back to WHO and other normative agencies, so we do what that's right and where there's evidence. Lastly, just focus on this. I wanted to bring us back to reality. In June of 2013, we launched our guidelines. Already around the world, a year, 2 years almost later, a year and a half later, we have more than 57% of countries in our 58 focus countries who have adopted greater initiation of at least 500 or more, 3% more. So those are the test and treats of Brazil and some other countries. But the reality of what we're seeing is we work also and support countries as they can make their global fund concept notes, that we have many countries that are not going to be able to even move beyond 350. So I'm a very practical optimist, but the reality check for countries are even if their national strategic plan wants to move to 500 or even beyond, or even accept some of the treatment as prevention options within the 2013 guidelines, such as B+, such as treating all Hep B or serodiscordant couples, they're very cash-strapped for making this a reality. And I think viral load, which is going to be our measure of the third 90, is going to be put on the back burner for many countries. And these are the countries with some of the highest burden of diseases. So just to end, I'll just say that our new guidelines hopefully will have a little bit more information about the how. We're doing work on quality of care, adolescent treatment, tiered care services, diagnostics, and the HIV comorbidity or NCD overlap. And we look forward to sharing that with you in 2015. But in the meantime, for the Cascade, we think this is important. It's a good use of data to be able to analyze populations. They need to be locally driven, and I think that's another good example of what the ambassador said this morning. And WHO remains committed to the optimization and the innovation parts of this in terms of across the drugs, diagnostics, and service delivery. And we'll work with some of the new initiatives that are coming out that would like to optimize, say, pediatric treatment and others. Thanks. That's it.
Thank you, Dr. Doherty, for a very comprehensive review. In the interest of time, we can take two very succinct questions. People are ready? Yes, please. It would be great, but why don't you first start and maybe Meg can repeat it.
And I am a woman living with HIV. Thank you so much. Thank you so much for the presentation. It's really interesting to have a complete overview of a WHO approach. And one of my questions, a burning question for me is, I saw that PrEP is represented as a matter of prevention choice for MSM. However, for discordant couples, there is a kind of very strong push for the fact that treatment as prevention is the option. As a woman living with HIV in a discordant couple, I feel that I should have, and all people living with HIV, not just in Western countries, should have treatment as prevention, as a prevention option, not as the prevention option. And I was also a little bit curious of what has WHO done to involve women living with HIV in the decision-making process of drafting those prevention guidelines. Thank you.
Okay, thank you very much. Shall I answer directly?
Yeah, I think maybe that will be the question.
Okay.
We should move on.
Well, I appreciate it, and I think it's an important comment, and I think that was part of the reason why my colleagues wanted me to make sure that I presented on the PrEP as well as serodiscordant couples recommendations. These prevention recommendations are always options. They're not a recommendation that it needs to be done 100% of the time. These are things that have to be negotiated between a healthcare provider and a person who does or does not want to take medicines, and so none of them are a requirement, and they are part of a broader prevention package, and they're an option among many, and so I would agree with that. In terms of involvement, we always have in our guideline development a large civil society who are part of our guideline development, and in the key populations it was 30% civil society, including women who are positive, men who have sex with men, transgender, people who inject drugs. So it was a very broad representation of civil society at that meeting. Thanks.
And thank you very much, Dr. Dougherty.